Continuing on with soft tissue injuries, so we'll talk about closed injuries. So they're characterized by a history of blunt trauma, pain at the site of the injury, swelling beneath the skin, and some sort of discoloration. So a contusion, fancy name for bruise, is an injury that's caused by bleeding beneath the skin that doesn't actually break through the skin so that epidermis stays intact. Small blood vessels are usually what is torn from that blunt force striking the body. Um, so the epidermis remains intact, but the cells of the dermis itself are damaged. And then you get a buildup of that blood in that space, which causes that blue, black, sometimes yellow, green discoloration. And that is called ecchymosis. A hematoma is when blood collects because of a damaged tissue or body cavity. When a larger blood vessel is damaged, bleeds rapidly, usually associated with some pretty extensive tissue damage. And then a crush injury is when a significant force is applied to the body and it's not like the other two closed injuries. So the extent of your damage is going to depend on the amount of force and the amount of time that the force was applied. Continuous compression of soft tissues ends up cutting off circulation, which then ends up leading to further tissue destruction on top of what has already happened. When an area of the body is trapped for longer than 4 hours, arterial blood flow is compromised and you can get what's called crush syndrome, which is super scary. When the patient's tissues are crushed beyond that repair, then muscle cells start to die and they release different harmful substances into all of the tissues around them. After the body part, whatever it is actually freed, then all of those harmful substances end up circulating and going to the heart and throughout systemic circulation in the body. So you need to have ALS providers on scene for crush injuries of this magnitude. They have to have IV fluids before the object is moved. They should have EKGs or monitors placed on the patient to watch for their heart. A lot of those toxic substances that come out or harmful substances end up affecting the heart and can put that patient into a lethal rhythm very quickly. So we want to watch very closely for cardiac arrest. And then a lot of those harmful substances also they just wreak havoc on your kidneys. Your kidneys are the ones that take the second brunt after the heart does. Compartment syndrome occurs whenever you have a bunch of swelling and pressure within a closed soft tissue compartment. So all of your muscles have a fascia that surrounds them. If you end up damaging the muscle underneath of that, but the fascia stays in check, it's very similar to your brain. There's no give to that. And so the more you bleed, the more that swelling builds up, the more it's just going to compress everything on the inside because the swelling can't go anywhere else. And now all of a sudden you've got lack of perfusion in there. You end up not being able to get oxygen and nutrients in. You can't get the byproducts out. And so it causes some pretty severe damage. You get pain, especially with passive movement. And the longer that it persists, the more there's a chance for tissue death. So we continually reassess skin color, temperature, and pulses distal to the site of an injury if a crush injury is suspected. But I mean, just even an injury to a large muscle group can cause this. Where we see it more often than not is a sports injury where somebody has taken a kick to the leg, especially the calf. Calves are really susceptible to compartment syndrome. But Severe injuries can occur even if they are closed injuries because a lot of force that's applied can cause more damage to the internal organs than to the external surfaces. Um, the greater the amount of energy absorbed from like a blunt force is going to cause greater damage to uh, internal organs and underlying structures. So we need to assess all patients with closed injuries for those hidden injuries because we might end up missing them. Open injuries, there's four main types. There's abrasions, which like I talked about is just more of that raspberry effect from sliding on a gym floor. You've got lacerations, avulsions, and then other penetrating wounds. You end up having a break in the skin with this, so now all of a sudden you've lost that protective barrier, which leads to more complications most often than not than those closed injuries. You can have both significant bleeding and contamination, so some stuff to keep in mind there. Here's kind of our abrasion. It's very superficial, caused by friction of the body part as it rubs or scrapes across a hard surface. Road rash is another good one. Um, Usually you don't have it penetrating down through the dermis. You might get blood that kind of oozes out depending on how far down it goes, but they can be extremely painful because all of your nerve endings are located in this area, but they just don't tend to hit a lot of those large blood vessels. Lacerations, these are a jagged cut that's caused by a sharp object or a blunt force that actually tears through the tissue. If you have an incision, that's a sharp, smooth cut. So it's a type of laceration, but just a little bit different. The depth of the injury can vary depending on what caused it and how much force. Lacerations may appear linear, which means just they're regular, they're straight, or stellated, which means they have irregular edges. Lacerations that involve arteries or large veins can result in severe bleeding. An avulsion separates the layers of soft tissue, usually between the subcutaneous layer and the fascia, so that they become completely detached or hang off as a flap. Often there's significant bleeding. We don't remove the flap. We leave that on there regardless of its size. An amputation is an injury where the body part is completely severed. You can generally easily control bleeding from amputations with direct pressure and pressure dressings because your body naturally vasoconstricts at that severe of an injury. It's when they calm down that things tend to get a lot worse. If there's massive bleeding, then you're going to apply a tourniquet because that can lead obviously to hypovolemia. But for the most part, meh. It just looks worse than, and the long-term ramifications are a lot more than what we're going to have to do for them right away. A penetrating wound, something pierces into the body. It can damage not only the surface structures, but it can go pretty deep within the body and cause some unseen bleeding. The presence of foreign materials that come in on the tail end of whatever that object is can also lead to infection. So we got secondary issues with that one too. Stabbings and shootings often result in multiple penetrating injuries. Oftentimes patients don't exactly know how many times they've gotten stabbed or how many times they've gotten shot. They just know that they have. So we definitely need to assess the patient carefully so that we can identify all of the wounds, count the number of their wounds, especially gunshot wounds, and note the distinction in entry and exit wounds. Typically, your entry wound is going to be a lot smaller than that exit wound. That exit wound, the energy just kind of pushes out and explodes, I guess, for lack of better description. And so they tend to be a lot bigger. If you have the possibility to identify what type of gun was used, it can help. Um, but we're not going looking for the gun. We're taking care of the patient first and foremost. It's helpful if you have bystanders to tell you how many shots you were fired or how many shots were fired. But when you're in that stressful of an environment, they're not really great at giving you a good history. You may have to testify in court for some of these, so make sure that you document a lot. For blast injuries, we already kind of talked about them. We've got the primary, secondary, and tertiary. Primary is caused by the wave itself with the sudden pressure changes of the explosion. The secondary is from flying debris. And then the tertiary is the victim being thrown by the explosion, perhaps into an object itself. Patient assessment of closed and open injuries. It is definitely more difficult to assess a closed injury than with an open injury. I mean, it's just visualization. You can actually see into an open injury. Scene safety is just like everything else. We're going to protect ourselves at a minimum, gloves and more than likely eye protection. Open soft tissue injuries can be very messy, but we need to make sure that we take care of the life threats and be very careful where you put your hands, place your equipment, how you package the patient, because there might be a lot of blood. And if we can keep our equipment out of it, definitely better. For mechanism of injury, look for indicators. Keep your index of suspicion high for severe injuries based on that mechanism. And then that MOI can also lead you to more information about the scene so that you can mitigate any safety threats that may be present. Your primary assessment, we're focusing on identifying and managing life-threatening conditions, just like everything else, getting our general impression. You want to know, is the patient still awake and interacting with the surroundings? Is the patient lying still making no sounds? If the patient's responding to you, are they responding appropriately? Look at their breathing pattern, color, temp of the patient's skin. And all of this you can get before you even touch your patient. So this is that doorway assessment, trying to get an overall idea as to what's going on. You can find like obvious severe bleeding at this point, so you know that you need to take care of that, and then you can continue to move on. Airway and breathing. High flow O2 can help reduce the effects of shock and helps with perfusion, but you want to make sure that the airway is open, protect the patient from further spinal injury. Open soft tissue injuries of the face and neck can be a problem with the airway. So we typically are going to use an occlusive dressing in that area, so something that air can't penetrate through in order to protect them. For circulation, same with everything else. Pulse, skin color, temp, text, cap refill if you need to, but typically the pulse and skin color is going to give you enough information that you won't need to use the cap refill all that much. And then your transport decision, consider the closest hospital or the most appropriate facility. There are certain patients that we want to transport more immediately. So if they have a poor general impression, you just have the gut feeling something's wrong, any sort of altered level of consciousness, shortness of breath or trouble breathing, abnormal vital signs, shock, and then severe pain. Patients who have visible significant bleeding or signs of significant internal bleeding may very, very quickly become unstable. So we don't want to be playing with them out in the field. We want to get them somewhere where they can get some definitive care. And we will continue on in the next one.